affected by HIV. It affects the same women who are affected by HIV, STIs, and the same group of women who are also experiencing poverty and other intersecting forms of, social issues. It is a deeply gendered health inequity issue, and it is linked strongly to poor water, sanitation, hygiene access. Of course, the gender dynamics in communities is one in which, women in particular are neglected in this situation because of the general way in which also women's health suffer, neglect in many cases. It can lead to pain, it leads to reproductive complications, and also other significant health risks. It's many times misdiagnosed as an STI, and it leads to long-term damage and even risk to HIV infection and other diseases. And it could also contribute to, antimicrobial resistance. Next slide, please. So I want to speak about it as a gendered health challenge, like I said in the previous slide. FGS affects women a lot because the mode of transmission through freshwater contact, it has implication on the kind of lives that women lead in these communities. So women who are the ones who are bearing, of course, the most burden of care work, washing in streams and rivers, fetching water, like you have seen in the photo beside this text, even in fishing, because women are also significant in many fishing communities. Women are also like very much involved in that sector. So because of that exposure, of course, there's higher chance of women getting in contact with Schistosoma hematobium than men in this case. The other issue is the fact that it is also misdiagnosed as an STI. And so there's shame and stigma because of the way in which FGS can present. There's clinicians on the call who will speak a little bit more to that later. But, there's sores, there's vaginal sores, and, it can look like an STI. And so when somebody hasn't, gotten an STI, but now has something that presents like it's an STI, there's a lot of weight of shame and stigma that they have to deal with. It can also lead to ectopic pregnancies, miscarriages, low birth weight. And so you see that it has its specific implication on women, especially on the reproductive women and reproductive labor of women. Complications of FGS also is associated with increased risk of contracting HIV and even HPV, that is known to cause cervical cancer. It can also even lead to faster progression of cervical cancer. I know that in Nigeria, there's been a huge drive and campaign, to uptake vaccine to prevent cervical cancer. But here is another challenge that can stand in the way of a woman truly living free of cervical cancer if this is not addressed. It can also lead to mental health distress, of course, and social exclusion, especially in communities where people don't understand what exactly, this woman has. We know that lack of access to health services for women and girls can exacerbate the complications and the risks that is associated with FGS. Next slide, please. So I just have just a bit of a connection diagram here to show the association of FGS and how it increases the risk of HIV acquisition. It increases the risk of HIV acquisition as much as 3 to 4 times. And so on the one side, on my right side, you have HIV acquisition. On the other side, you have FGS. We know that FGS also, FGS, like I've shared earlier, it leads to, increased risk of sexually transmitted infection. It can lead to vaginal inflammation. It can lead to non-optimal cervical-vaginal microbiota, a situation in which the natural flora of the vagina, which has, bacteria that is supposed to help to keep the pH of that environment a certain level, that is altered, when there's FGS, and that can lead to that imbalance can cause so many things, including like, the microbial resistance that we're talking talking about including the increased risk to the reduced immunity of that area from, the protection that the natural bacteria is supposed to provide. It now makes it more susceptible to, other kinds of infection. The same, of course, can be said for HIV acquisition across these three issues. And you see then how FGS can lead to, increased risk of HIV acquisition. Next slide, please. So ending the neglect actually begins with recognition. I want to assume that for many people who might be on this call with us, this might be sounding like something, really novel, but if we're going to end the neglect of FGS, we need to start with recognizing, what this disease condition is, what this is about, how it is addressed, and what all of us can do about it. So there's limited awareness among healthcare providers. Like I said in the earlier slides, there's a lot of misdiagnosis happening because the way it presents, healthcare providers can easily name it something else like what they have seen. Yeah. There's also no national guidelines for FGS as of now in Nigeria. We don't have a national guideline. And we know what national guidelines do in helping actors like you and I, and even healthcare providers, to address such health conditions. There's also a weak integration into SRHR and HIV services. In Nigeria, the FGS conversation sits within the the neglected tropical diseases portfolio. But because of the nature of this disease, there's need for that integration into SRHR and HIV services. And this integration is weak as of now. We also know that praziquantel is not routinely available for women. Outside of the situations of mass drug administration, there's rarely situations of women being able to access praziquantel, which is treatment for FGS, at facilities. Next slide, please. So where can we then flip the curve? Of course, we know like there are strategic moves that can be made in order to address this this issue. One is policy and health financing at both state and national level. And an important intervention in that regard is to mandate that FGS is in SRHR and NCD policies and budgets. Just yesterday, there was a meeting, there was an engagement with the Ministry of Health and Social Welfare in which neglected tropical diseases were being discussed in general, including the progress Nigeria has made with onchocerciasis and so on and so forth. Well, I did not hear FGS, but it was important for me. I found it important that that conversation was happening at that level, involving even as high as the Minister of State for Health. And in the Minister of State statement, he actually made put out a thing that states should commit to budgeting for neglected tropical diseases. That's the kind of action that we need to start seeing to be able to flip the curve, where at national level and at state level, policies and budgets are recognized, that this is a low-hanging fruit. We can address FGS and we can include it in, what we are planning for. So in the country's health plan, in the country's development plan, we need to see FGS as a disease area that attracts attention, that is given attention. Another strategic lever is frontline service delivery. There's need to build diagnostic capacity to be able to diagnose correctly. There's need to incorporate screening and ensure that treatment is available at facilities. It's also important for us to address community systems. We know that because, anything that has to do with a woman's reproductive system, organs, and so on and so forth, is shrouded in a lot of, secrecy and, so many things culturally that does not allow for women to, experience. When women experience such a thing, they don't have the courage and the confidence to approach facilities. So we must normalize conversations on genital symptoms, so that if a woman has a symptom of an illness that is presenting in her vagina or in any of the genital areas, it doesn't become something of shame because it is part of our bodies. So we have to learn from work that has been done in HIV and SRH. We know how far we have come in the HIV movement over 2 decades in my own experience here in Nigeria and the work my organization has been doing, we know how we've been in conversations around destigmatizing issues of SRHR and HIV. We must transfer such learnings to the FGS situation as well. We must transfer such experience to FGS and how we engage communities around addressing the issue. Of course, we must look at water and sanitation and hygiene facilities. We will hear from our colleagues, subsequently after my presentation about the data, where exactly this is. So we must target those endemic local government areas with water access investments, with investments in water facilities, sanitation facilities that can help prevent even contact with the parasite in the first place. The last one on my slide here is research and evidence. We need to have more evidence. We need to have more documented research that supports implementation. Next slide. So what will success look like for us? In the next 3 years, if FGS is integrated into national health sector strategic blueprints, priority interventions, and if FGS is integrated in the national STI guidelines, in the HIV national strategic plan, in the NTD master plan, if we start to see FGS mentioned in this key policy document, that's success. We want to also see routine screening of women and girls in the endemic local governments, and not just wait for when some people have some resources to do those mass drug administration that happens within school. So we want to see more routine screening of women and girls in the local governments that it's endemic. We want to see more healthcare providers trained, more reproductive healthcare providers trained at primary healthcare level, because the women and girls who this affects are able to, their first point of contact, everybody's first point of contact is the PHC. But if you look at the specific groups of women who this affects, you will know that the PHC is really the only options that they have most times in terms of coming in contact with the health facilities, with the health system. So there has to be trained providers at that level. And communities must be aware at a large scale, even beyond the communities where this is endemic, there has to be large scale community awareness about FGS. Praziquantel has to be available as well in PHCs to match that trained providers can actually provide care. Investments in WASH, of course, is also critical to the areas that are mapped as hotspots for schisto. Next slide. Next slide, please. So what are we proposing here? The previous slide, please. We're proposing that FGS, the value proposition here is that FGS has to be addressed through integration. And that this integration, it is a low-cost integration and it's a high-impact win. By the time you hear from other speakers, you know that this is actually not a very expensive thing to address, to treat. And when we do that, there will be high impact for women at scale across maternal health, even addressing infertility and also HIV prevention. And very importantly, of course, when we do all of this, we are also addressing gender equality, because the women who are affected are in an intersecting form of inequality. Poverty, lack of education, poor social economic outcomes, environments that don't have, all of the social determinants of health that we know. These are women who are on the very low scale, low cadre, low levels of the social determinants of health. So when we address this, we are also contributing to addressing gender equality. And so my call to action. Next slide. My call to action for, global action, as well as in Nigeria specifically, as we're talking about this, is that female genital schistosomiasis must be reframed as a mainstream reproductive health priority. It is a reproductive health priority. Of course, there's established connection between FGS and other reproductive health infections, SRH, HIV, even infertility. So this has to receive priority intervention. FGS is a silent epidemic that bridges women's health, poverty, and gender justice. And addressing this is not just a medical necessity, it is a reproductive rights imperative. I want to thank you for listening, and I will be handing over to the next speaker, Professor Joy Schwaibu, who will take on the conversation from here. Thank you very much.
Thank you
Thank you.
so much.
Thank you very much, Tony. I think you have set the tone for this webinar, and I want to thank everyone for joining us today from wherever you're joining us. My name is Joy Shuaibu. I am Country Director for Site Savers here in Nigeria, and Site Savers is at the forefront globally for the fight against neglected tropical diseases, of which schistosomiasis is a part, and FGS is a complication of. And Tony has brilliantly provided details of what it is and what it is about and why we're looking at it holistically in this webinar. So just to point on some of the things that Tony has mentioned. Female genital schistosomiasis is the most common gynecological problem in areas that are endemic for schistosomiasis. But like Tony had also mentioned, this often goes undiagnosed because it's not something that people are aware of. And this condition affects women in rural areas for obvious reasons, because they are the ones that do not have access to clean water. And like has been mentioned, it is a very important public health problem for us as an organization, because we're not only fighting neglected tropical diseases, but we're also ensuring that there's equity and equality and a level playing ground for women. So there's a lot of intersection when it comes to the fight against female genital schistosomiasis, because there's a medical component to it, there are social determinants also, and we know that if women are liberated and they're able to live healthy lives, we can achieve much more as a nation and globally as well. Next slide, please. So one of the things that was mentioned by the previous speaker is that we're trying to drive evidence, because we want female genital schistosomiasis not just to be heard, but also to be seen. And why, as site savers, we went ahead is because we usually like to come to the place of advocacy with evidence and facts. So we decided we were going to conduct a study to determine the prevalence of female genital schistosomiasis among women aged 15 to 49 in 2 states of Nigeria. And the reason we went about doing this is because of the gap that exists in terms of identification of female genital schistosomiasis at the primary healthcare level and a very poor understanding of the disease. And we feel that if we're going to make any form of contribution significantly in this area, it is important to also identify the barriers that exist for women who are infected with schistosomiasis of the genital tract from seeking appropriate health care. So those were the things we had in mind when we set out to do this study. Next slide, please. So what we did in the course of our study was to do 4 different things. We had data collected, biodata of these women. We also wanted to hear about their gynecological symptoms. We also did a risk assessment of these women, but we went ahead also to do some diagnostic testing of urinalysis. We did microscopy for those who required, and also colposcopy, which is a bit more invasive, just to establish the diagnosis of female genital schistosomiasis. Next slide, please. So this study was done in Ondo State and Kebbi. Maybe to mention that schistosomiasis is actually a disease that affects almost all the regions and all the states in Nigeria. But of course, since this was a research, we took a sample, one from the southwest and one from the northwest part of this country. So in Kebbi and also in Ondo, we had a total of 665 participants in the study, and 561 of those participants eventually had colposcopy done for them as well. Next slide, please. So what did we find out? We found out in this sample that there were 5.8% of the people that were sampled had female genital schistosomiasis. And a diagnosis based on visualization and using the colposcope was able to identify 41.4% of these people who had um, female genital schistosomiasis. Next slide, please. So what did we learn? What we learned from this study is not very much different from what has been mentioned, that this is a disease of public health importance. And because looking at the prevalence that was recorded, it's important that it comes into the attention of the healthcare system. And just like Tony had mentioned, this is a sexual and reproductive health issue because it does not only affect the quality of life of women, but also opens them up to the risk of cancers and other sexually transmitted infections. We have also noted from our study, just like has been mentioned, that conversations around female genital schistosomiasis is an opportunity to strengthen the health system because what we realized was that there's a poor knowledge and awareness of FGS even among health workers. And I dare say that the primary healthcare workers, just as Tony has mentioned, who most likely will be the only source of healthcare or access to healthcare that these women have, do not have this awareness. And so if we're going to make any lasting impact in terms of bringing it to the fore and addressing issues of female genital schistosomiasis, it's important to strengthen the health system in order to be able to identify this condition just by doing a risk assessment, just by doing just simple diagnostics so that the diagnosis of this condition can be established. We realize also that we do not have enough equipment and even the technical capacity to make diagnosis for female genital schistosomiasis at the primary healthcare level. And this is absolutely important. And in our fight against female genital schistosomiasis, it's not just the medical or social. We also need environmental actors. WASH, because as has been mentioned, it's the women who go to the stream. It's the women who get exposed to water that is infected by schistosomiasis. So it's important for the WASH actors to come alongside. And this is even much more so now that we're having situations where even in urban areas, there are water bodies that also contribute to schistosomiasis. So this is absolutely important that we continue this conversation on female genital schistosomiasis. Thank you very much, and I'll hand over to the next speaker.
Thanks so much, Joy. And I think Toyin and Joy have really done a great job in explaining the importance of FGS and why it needs to be addressed, but also what it's looking like in Nigeria. Based on the information that Toyin has mentioned around the links of HIV and FGS, we thought it also important to show you a little bit of data around HIV prevalence in Nigeria and FGS. Just to be clear, we cannot specifically state that there is a link between FGS and HIV specifically, and this data does not highlight the same women and girls, but it does show an ecological trend that does need to be noted because it is the very same women and girls who are facing risks of HIV, STIs, HPV, cervical cancer, and are living in poverty that are at risk of schistosomiasis and FGS. So in Nigeria, the HIV prevalence is 1.4%, and this picture really highlights some of the key states and areas of Nigeria where there is high HIV prevalence. But the next slide really shows the overlap between HIV and FGS. So analysis of state level data really does show an overlap of states, those states colored in red, which have high HIV rates, and also where FGS risk is highest, meaning there is schistosomiasis in those states. And so there is a risk of the same women and girls who are at risk or living with HIV and are at risk of STIs or cervical cancer are also at risk for FGS. And so it just really highlights from an ecological perspective the importance around integrating approaches in Nigeria, and making sure that FGS is integrated into various programs, as Toyin and Joy have highlighted, from SRH, HIV prevention, WASH, and various interventions. So that's just a little bit of data for you to understand some of the data elements within Nigeria, specifically to FGS, as Sightsavers has presented, but also the HIV prevalence. I'm now going to hand over to our FIG partner, the FGS Society of Nigeria, to present on advocacy efforts.
Good day, everyone. I'm Dr. Ibrahim Rabiu, the National Coordinator of Female Genital Schistosomiasis Society of Nigeria, a leading platform advocating for recognition, prevention, and management of FGS within the national and global health agenda. FGS has been missing historically from Nigeria's public health agenda. In 2021, FGS scholars in Nigeria recognized the need for coordinated national advocacy to break this silence. And in 2022, FGS Society was actually formed to fill this advocacy and coordination gap. The society is a national platform that brings together researchers, medical professionals, advocates with the mission to end the neglect and improves women's health through awareness, research, and action. The society was registered within, appropriate body in Nigeria as a grassroots non-profit public health organization. Please. Next slides. Next slide, please. In 1975, no, please go back. Go back, please. Okay. Yeah, in 1975, cases of FGS were reported from autopsy tissue from University Teaching Hospital in Ibadan, Nigeria. In 2016 and 17, a pilot study was done in some communities in Ogun State, where among the 47 women that consented for colposcopy, 38.3% of them had features compatible with FGS. In 2003/2004, a committee-based cross-sectional study was done in Zamfara community in Gombe State, and we found out that 9.3% of the women who consented for colposcopy had FGS. It is important to note that FGS of upper genital tract had from Nigeria, one from Aminu Kano Teaching Hospital and two other from a teaching hospital in the Northeast, FTH, Federal Teaching Hospital Gombe, and Federal Teaching Hospital, Adamawa State. Recently, we've just concluded multi-country assessment prevalence for FGS survey in 6 countries, Nigeria included, and the report we are about to publish it, and then it will add to the evidence of FGS in Nigeria. Next slide, please. Yes, what are the strategic approaches that FGS Society has used for advocacy? You've used evidence-based advocacy by using the information we get from research to advocate for FGS. You've used social and traditional media to create awareness in Nigeria and across the states in Nigeria. And one of the approaches is inclusion of women's voice and then the life experience. Those that had experience FGS, they take it upon themselves to also create awareness among the populace about FGS. And we've used multi-sectorial partnership. We partner with health sector, education sector, because if you look at it, not only FGS not mentioned in our curriculum, nothing is said about it. It's not discussed. So we collaborate, we partner with health sectors, education sectors, and women association and gender sectors to create advocacy. Next slide, please. Next slide. Yeah. What are the key advocacy milestones FJ Society has achieved so far? We have engaged policymakers at federal and state levels, tried to make them see the reasons why FGS should be included in our policy document. Uh, September, we are in WHO headquarters in Geneva to contribute to WHO informal consultation on genital schistosomiasis, include FGS. In Nigeria, we partner with academic and public health institutions. We are in touch with tertiary hospitals and universities in order to create and do research about FGS. And you have also create awareness campaign across all states in Nigeria with the aim to bring FGS to limelight. Next slides. Yes, these are some of the pictures from our galleries that shows our advocacy events. We have done FGS at national level where personalities from the federal ministries and other organizations were there. In advocacy to state ministries and LGAs. You can see some of my colleagues at the television station creating awareness of FGS. This is my humble self in Geneva, where we are discussing about schistosomiasis, genital schistosomiasis, and FGS. Next slides. Yes, these are my research team at Fieldwork in Zamfara community, Gombe State. These are our youth champions that take the messages of FGS awareness to the various communities in Nigeria. They are medical students. This happened during their health weeks. Next slide, please. Yes, we've taken advocacy to various community leaders, and this is just one example. And we also work around communities with my youth representatives and champions to create awareness among FGS in Nigeria. Next slides. Yes, what are the lessons learned from our advocacy, and then what are the way forward? One thing that is very important is that advocacy must be continuous, and then it has to be multi-layered. You have to involve various partners and sectors. So one of the way forward is that you have to scale up this advocacy to all local governments, areas, and wards in Nigeria. Yes, you've touched some local governments and wards, but there's still much work to do. And partnership amplify visibility and credibility. So the way forward, we have to strengthen integration with HIV, cervical cancer, sexual and reproductive health programs. In the long run, FGS has to be integrated into the large health sector plans. Data and evidence are powerful advocacy for tools. So we are calling for establishment of national guidelines for FGS in Nigeria, and also we have to establish data tracking for FGS in all states in Nigeria, local governments and world, so that it can be used for advocacy and other things. Next slide, please. Next slide. Yes. The other lesson learned is stakeholder engagement ensures sustainability. So because we engage stakeholders, we are able to sustain some of the activities we are doing. So one of the way forward is that the policymakers in Nigeria has to, include FGS in our policy document, and our partnership with the Ministry of Health has to continue. At the state level, it has become necessary to establish FGS focal points. Not only that, you have to build the capacity of our health workers at the state levels and also strengthen media sensitization. It helps a lot so that awareness about FGS can be created. And don't forget, we have partners with professional associations and NGOs. So we need to, partner, cut across other professional bodies and other relevant NGOs to sustain this advocacy. Women's leadership is critical for success. If you look at our organogram, we have most of our leaders, the zonal coordinators, they are women, the state coordinators are women, and even our at world level. So we need to build a strong FGS champions network, not just in Nigeria, across the world, to fight against this FGS. Health impact, and where awareness has been created and FGS is rightly diagnosed, paracetamol will be given, meaning it will reduce unnecessary use of antibiotics, and this has actually leads to reduced risk of antimicrobial resistance. So we are calling for integration of FGS screening into routine sexual and reproductive health services to minimize misdiagnosis as STIs. If you do that, antibiotic will not be used unnecessarily for FGS, and the issue of antimicrobial resistance will be curbed. Next slide, please. Yes, I would like to conclude by calling people on this call that please join the FGS Society of Nigeria Advocacy Network. You can, if you are in Nigeria, we become our local members. If you are outside Nigeria, we'll give you international members. You're highly welcome. Collaborate on campaigns. Please join us. Let's continue the FGS awareness during World NTD Days and International Women's Day and other relevant days. Please support our state level initiative such as advocacy, sensitization, research, and referral activities. Let us engage in policy dialogues and cross-country learning on FGS HIV integration. Help us amplify FGS visibility through your social media and your professional platform. We need to secure more praziquantel for our primary healthcare centers because the MDA praziquantel is not enough to take care of FGS. Last but not the least, and most importantly, please help us connect the society to funding, technical and institutional partnerships so that we can continue doing our activity at the best level. Thank you. I think I hand over to the next presenter, Dr. John. Thank you for listening.
Okay, so thank you everyone, and then thank you for joining the webinar. I'm Dr. John. I'll be speaking on the perspective of national strategies for addressing FGS within HIV and STI response. Next slide. So the current gaps and challenges in Nigeria. The gaps identified as HIV and STI programs operate separately from FGS responses. Another gap is low awareness among health workers of FGS. Another gap is limited diagnostics for FGS. And then the other gap is data systems do not track FGS in HIV/STI surveillance. The last gap there is weak policy or guideline integration, which most of the panelists have actually highlighted. Next slide. So the national strategy pillars for integration, we are looking at it from the point of one, Policy and guideline inclusion. Maybe we start from that level by including FGS in national HIV/STI guidelines, defining roles of HIV, STI, and NTD units. I think many people also call for that. Then another point is capacity building and training. Train the healthcare workers, provide job aids and mentorship so that they'll be able to do their job. Then the third one is diagnostic and service delivery. Introduce FGS diagnostic tools. Ensure private quarter availability in country, which most of the panelists have called for. The fourth is surveillance and research. By add FGS indicators and promote operational research so that we can actually be active in tracking. And then the last one there is community engagement and awareness. Campaigns targeting women and those suffering from FGS. Next. So examples of possible interventions that we may take. Joint screening days. So it could be an intervention that we can key into by the HIV and STI clinics offering FGS outreach. So if we do this, it will be beneficial in identification. Mobile clinics combining HIV testing, STI treatment, and FGS assessment. They should also be encouraged so that they can get to the hard-to-reach areas. And then integrating FGS awareness into HIV counseling and testing sections will be a key achievement that will benefit everyone, the entire health sector. And then partnering with community health workers to educate and refer women for FGS care. This will help because they are there in the community. They will be able to identify the cases and send to us. So implementation considerations and barriers. Funding is a key consideration and barrier. Securing resources for diagnostic and services will be key and very important. Human resources, we need them. Staff overload and limited specialists have been a challenge, and therefore we need more training on human resource and getting more of them there. Quality assurance, ensuring consistent diagnostic and treatment will be very key. Cultural sensitivity, also making sure that addressing stigma and gender norms within culturally addressed things will be helpful. And coordination between the HIV, NTD, and reproductive health programs within the ministry will be very helpful, just as we are doing now. Then procurement of private quarter outside MDA, that will be fine by making sure it is available outside the MDAs. Next. So the measuring success, if we do all that we want to do and go the way we want to go, it means that indicators such as proportion of HIV and STI clinics with FGS screening, number of trained health workers, all this will be part of indicators that we can use to track our progress. Reduction in misdiagnosed STI cases due to FGS will become one of the indicators that we can also use to track our programmatic interventions. Then improve patient satisfaction and earlier diagnosis will be another one whereby the patients will find out that most of them, they will tell you they are fine and they are better and they will approach it and embrace it. Use of data to refine and scale up intervention will be something that, because we now have data to all the other indicators and then we can use them to make sure we improve our services. Next. So the call to action here will be 1, integrate FGS into HIV and STI national policy and national strategic plans for health immediately. And this we can achieve by those of us that are on the call and all the panelists working together at the back end in country to make sure we have a stakeholders meeting to address it virtually or hybrid. Then train healthcare workers on FGS. So from the stakeholders meeting, we'll be able to now get the guidelines they talk about and then get the training module, and people can also continue to use it. Mobilize stakeholders, for instance, Ministry of Health, donors, and NGO, everybody coming together to do the needful about that. Then prioritize awareness and community engagement as one of the interventions so that we can get the community on our side. Allocate budget lines for FGS, including diagnostic and private quarter at national and sub-national. That would be very helpful to make sure there's enough funding for this intervention. Over. Thank you.
Thank you so much, Doctor. I would like to welcome Aliyah from Global Fund Women before we go to our Q&A section. Welcome, Aliyah.
Thank you, Linda. Hi, good afternoon, everyone. My name is Ali Amimi, and I serve as the Gender Advocacy Lead at Women for Global Fund. And it's a pleasure to be here today and to share my reflections on how we can integrate FGS into the Global Fund's modular frameworks and also gender assessment with the particular focus on Nigeria. And today I will walk you through, why FGS must be seen as a critical gender and HIV issue and as a core component of gender transformative HIV response. So for the ones who don't know Women for Global Fund, so we are a global movement of women advocates. And our mission is simple and powerful. So we catalyze the power of women in all their diversity to advance gender equality through the Global Fund. So we bring together women rights advocates from across the world to really ensure that the Global Fund's decisions, investments, and programs truly reflect women's priorities and women's needs. And our focus is to ensure that the Global Funds really delivers gender transformative results. Next. Why are we talking about FGS today? The speakers already presented this and said that it is neglected but serious women's health issue. And FGS increases the vulnerability to HIV infections, and they both, disproportionately affect adolescent girls and young women in underserved and high burden areas. And beyond this, the social barriers make things worse. So we have gender-based violence, stigma, discriminations, limited access to SRHR services. Also, health providers often lack trainings, which leads to misdiagnosis and missed opportunities for integrated cares. So integrating FGS into the HIV services, it's not just medical issue, it's about gender justice and gender equity. Next. So regarding the modular framework, the Global Fund modular framework, it's actually the document that you see in this picture, and it's basically a structure that guides how countries design their funding requests that they submit to the Global Fund for each cycle. So this tool groups all the activities under standard modules and interventions, for example, HIV prevention, treatment, health system strengthening. If we want FGS to be part of the national HIV response, we need to make sure that it fits into this modular framework. And it means that we integrate FGS related activities under the existing modules of the HIV modular framework, rather than creating a new one. And it is possible. So we can add the FGS in the modular of screening, prevention, treatment. We can also fund community awareness and education about the link between FGS and HIV. We can support women-led, youth-led organization to lead the outreach, to lead the advocacy, and it's completely possible. So here you also find a Women for Global Fund GC7 tool. It's a guide that helps women's advocates to understand exactly how to influence the Global Fund process and to actually know the entry points to make sure that they participate meaningfully in all the process. And it shows where the cycle begins and where in the cycle we can bring in gender priorities like FGS. So the next cycle will start next year, cycle 8. And here we can see that FGS can be included, for example, like I said, under HIV prevention, the SRHR modules, the community systems and response, And so instead of saying that we will need a new program for FGS, we will advocate to say that we need to expand the existing programs in the HIV services and to include FGS. Next. So here I will present some concrete steps where women advocates can or CCM members can take to advocate for the integration of FGS in the Global Fund funding request, and it is actually from a women's rights and gender equality perspective. So as Women for Global Fund, we always advise women advocates to use specific moments like the country consultations, the CCM meetings, where they can raise FGS as a women's health and HIV issue, and to use different tools, to use data, to use testimonies, to show the impact of FGS on women's health. Also to try to integrate FGS in the situation analysis of the funding request, and to make sure that it's actually one of the funding request templates where you present the context analysis of the country, and especially where gender and HIV are discussed. So we need to have clear data that present, the impact of FGS. And also try to place FGS under existing modules, like I said, and propose simple, practical activities to be funded, like, for example, training health workers, integrating screening, also the procurement of basic treatment and medicines. And all of this can be fit into the existing budget lines within, the HIV service package. So during the meetings, we need to make sure that we bring FGS into the Global Fund's agenda without reinventing the wheel, but including it in the existing budget lines. Next. Now we'll look at the second entry point, which is the gender assessments. So the gender assessments were launched by UNAIDS in 2010 to make sure that we assess the HIV response. We have an evidence-informed planning and budgeting for the gender transformative HIV response. And this really assessment can give, a gender transformative evidence-based response. And if we include FGS in this assessment, we can really highlight the needs of women and girls that are affected by FGS. We can assess their access to SRHR services and also to HIV services. It's also a tool to document stigma, discrimination, and its effects, and also to use the evidence to advocate for FGS in the funding request. So Women for Global Fund supports organizations to find out if there is a gender assessment conducted in their countries, and also to reach out to UNAIDS offices to know, if there's this possibility to conduct a gender assessment, and to make sure that women's advocates can really influence changes of the review of the National Strategic Plan, and also they can participate to the funding request process and inform the funding requests that will be submitted to the Global Fund. Next. So after conducting the gender assessments, we can lobby for the recommended gender FGS related interventions that can be included in the Global Fund concept note and final budget. We can use the final gender assessment report to mobilize additional funding. It's not always related to the Global Fund, but we can find other international donors that may be interested in funding FGS response, and also to share the findings of the gender assessment to create awareness, to raise awareness, and to really strengthen advocacy coalitions working on FGS. And this follow-up stage is really important because this is where you can use the findings of the gender assessment and you can make some changes and you can, I mean, your advocacy can really turns into concrete actions. Next. One of our recommendation as for women advocates is really to make sure that they know how to navigate the CCM. And we have developed a guide, a 10-step guide that is a very important tool for women to understand how decisions are made in the Global Fund. I mean, the Global Fund processes are really complex. They are changing every time. And women advocates don't have access necessarily to these informations. So we advise them to really understand how they can strategically advocate within the CCMs. They need to find, to identify allies inside the CCMs that are working, for example, on FGS. They can build to create coalitions to push for gender equality and SRHR. They can also, during the CCM meetings, know when is the right moment to introduce FGS as a priority issue during the discussions, and to also discuss the budget allocations to reflect women's health and women's needs. So this is where women can really make sure that FGS doesn't stay on the margins, but it can become part of the funded national HIV response. Next. Thank you. So I think for this call to action, I will join all the previous panelists and to make sure that our call to action for us for the Global Funds Cycle 8 is to make sure to integrate FGS in the gender transformative HIV response, to make it visible in GC8 country dialogues and the funding request, and to make sure that we are investing in women-led and community-driven approaches that can really connect HIV prevention, FGS care, and also SRHR to make sure that we advocate for training and equipping healthcare providers and to really fund data collection and research to finally close the knowledge gap about FGS and its connection to HIV. Just I mean, in closing, to say that I mean, Women for Global Fund is available to support you in your advocacy and in addressing the root causes of women vulnerability to HIV, and also how we can integrate FGS into the HIV response. Next, please. So if you would like, please connect with us on our social media, or you can reach out to us directly. You can contact Angela, our global coordinator, or myself using the email that we've put in the next slide. Thank you again, and I look forward to the questions.
I was on mute. Thank you, everybody. Thank you, Aliyah. Thank you to all the panelists. I think it's a great time for us to have a Q&A sections. If you have a question, please use the electronic hand and I'll quickly pick it up. But before we get to the electronic people who have questions, I did pick up some questions from the chat box, and one someone said, in the absence of coloscopy devices in primary health care, what is the feasibility of using smartphone by trained primary health cares as replacement for coloscopy examination? I think someone asked that question. Anyone willing to take it up?
Yeah, thank you so much for the question. If you look at it, you have various form of colposcope. you have the mobile one, and then we have the fixed one that you can find in the tertiary hospital. Yes, if you have the smartphone available, there's this policy we call tax shifting and tax sharing Nigeria, which in Gombe, that's what we are doing. So we can actually train those people working at PhD level to be using the smartphone colposcope, to carry out the examination. It's not so we are doing that in Gombe, at community level. Would you go there and train them? So I think it's a good option, to diagnose the FGS at PhD level. Thank you for the question.
Great, thank you. Someone did ask for Women for Global Fund contacts. There they are. Another question was nice. I think this is directed to Toyin. Nice presentation by Toyin. However, praziquantel treatment is in resolving FGS is debatable. Early access to praziquantel to prevent FGS is being advocated. Yes, the Ministry of Health need to set up a technical working group on FGS. I think it was more of a comment.
Comment exactly
Yeah.
than a question. And just to say to the person, of course, like what we are advocating in terms of giving attention to FGS is policy, budget, actions that actually elevate the situation, to a place where adequate priority is given to it. And for the issue of praziquantel and its indication in, FGS, I'm not a clinician here, like Dr. Rabiu is here. I think Professor Joy, maybe you also can speak to that. But as far as we know, that is what has been used in mass distribution, in schools and so on for FGS. For now, we need that it be available at the primary healthcare facilities. If it is still being in contention in any situation, if it is, as long as it is indicated, for now, it needs to be available at the PhD level. The other thing is about guidelines, because when we have guidelines at that national level and at the state level, then there's clear pathway to how, to manage the disease, for how to manage the condition. So we're also calling for the guidelines to be clear, and whatever the guidelines stipulate, as far as the Ministry of Health and Social Welfare is concerned, that then becomes a blueprint to be followed for addressing FGS. So that's what I would say about that. Yeah, thanks.
Yeah, thank you, Joy. Yes, if you look at FGS, you are talking of the lower aspect. There are various pathologies there, that if you give FGS at early stage, some of it will resolve. So that's why we are calling for, sorry, if you give a praziquantel at early stage, some of this feature will resolve. That's why we are calling for availability, because the one for MDS is meant for school children. And FGS doesn't, the one for Schistosomiasis is meant for school children. And FGS is not only the school children are affected, even women that are not going to school. So how do you address their case? So actually there are some of the features. Yes, is the pathology is going to the egg, is due to the egg of the parasite, but then study has shown that some of these features resolve if you give praziquantel at early stage. Thank you so much.
Great. Thank you, Doctor, for your response. Do we have any other questions? Please feel free to use the electronic hand. And speakers, if you're interested to contact anyone, the panelists are free to share their contacts in the chat box. If someone has needs to further explore this topic and how to join the movement. And there is a question from Ahmad Musa. He's asking, how can I join the advocacy of FGS? And I think any of the speakers can come
Yes,
up and
thank you.
yeah.
Thank you for the question. If you look at the organogram of FGS Society of Nigeria, you have the zonal, you have the state, and then you have the world. And then we have a platform, WhatsApp platform at each state level, that anybody that want to join, to just, I will connect them and then they will join them based on the state is coming from in Nigeria. And what we are moving towards now is how do get this society across West Africa and Africa. I've discovered my colleague in Ghana and in other country, how do you make this thing an international one so that you can have people joining and then we continue the advocacy together across the world. Yes, for Nigeria, we have platform. If you want to join, my address is my contact is in my slides. You can contact me, and then I will put you from the state you are coming from. Thank you so much.
Great.
Linda, if I can add, I think if you're interested in supporting FGS advocacy, I think you can definitely get some of our contact details of the speakers here and join the cause. But I think based on what Alia mentioned as well, wherever you work or whatever role you hold, you can play a role in just making people aware of FGS and highlighting the need for it to be considered in national policy. And particularly if you have any role related to the Global Fund or you know of any representatives on the country coordination mechanism or within PRs and SRs, you can play an advocacy role there on making sure that you make people aware of FGS. So I think wherever you sit, whatever your role is or whatever organization you're in, you can take this information that's been provided to you today, and we can always share more information with you if you would like. Just indicate in the chat and we'll share contact details. But you can definitely contact Women for Global Fund, you can contact FIG or any of the speakers, and we can support you because we are just really hoping that everyone at this webinar will feel passionate about FGS and take it up in whichever space you're in to make governments, organizations, people aware of FGS, but also understand the need to have it integrated.
Great. I think we don't have any more questions.
I think there's a question from Dr. Ibrahim.
Okay.
Yes, in the chat, someone has asked about moving, the shifting from school-based to community-based sort of interventions. I don't know if Dr. Ibrahim wants to speak about it. Or I can say one thing though before that. For what we're saying about the intervention so far being school-based, it's not as if to say we should stop the school-based administration of praziquantel. We're saying that it needs to be expanded because the women who are affected are also not just in schools. So there's need to expand this beyond the interventions within the schools, not to stop that all totally. So if government also now makes this a priority budget for this, then they can plan for women and girls outside the school system. I think that's an angle in terms of advocacy. But Dr. Ibrahim, maybe you want to also speak something about that.
Yeah, thank you so much. I think there's what you call MDA extended. This WHO program. MDA extended, though in some states in Nigeria they've started implementing it. It's not just going to school to give MDA. We also go to the community. So we are not saying the MDA should know. We are saying that let's put in practice, the WHO policy of MDA extended, whereby also give MDA in the school and also give it in the community. That's what we are saying. And as I said, some states in Nigeria have actually started that MDA extended. Thank you so much.
Thank you. There are two people who have their hands up. I'll go ahead and allow Dr. Zainab Kwaru to pose her question, then followed by Abduli. Welcome, Dr. Zainab.
Yes, thank you very much for Hello. Hello, can you hear me? Sorry.
Yeah,
Hello?
yes, we can.
Yes.
I want to particularly thank Dr. Rabiu for inviting us for this webinar. And I'm sure our participation has really given us insight. I'm the national president of the Medical Women's Association of Nigeria. I think one of the things that we do is to focus on advocating for women's health and children's health. And what more than playing that key role of contributing to the advocacy effort. I'm also happy to see Toyin, EVA, and I think a lot of the work that is being done under these platforms contribute to creating awareness and also mobilizing so that there's an uptake and a recognition of this very particular condition of FGS. So my question here, I know you've given us some contacts. How do we, as a Medical Women Association, key into this program and perhaps also support the initiative of creating more attention and perhaps also contributing to the policy work that is expected? We are in 36 states of the Federation, including the FC, and I think it's important if we can use such a platform with these large branches that we have to convey the message and perhaps play other role that NGOs like ours can do. So I'll need to have more information regarding that and what more can we do to actually contribute our own quota to addressing the issue of FGS across the different parts of the country. Thank you and over.
Can I respond? Hello?
Go for it, Dr. Ibrahim.
Yeah,
Yes, go ahead.
yeah. I think I want to say that I'm honored to have the president of Nigerian Medical Association here with us. It's an honor to me. Thank you so much for joining our webinar. I think a few months ago, I was in Kano for West Africa College of Physicians conference. We met and then we discussed, and then I promised her that I'm coming to that conference in Kaduna State. I was actually there. So we are going to collaborate with you. And if you look at it, even in Gombe, I think a week ago, the Gombe chapter, we joined together and also made an awareness across the communities in Gombe. So that's what we want to do, across all the states. We are ready to work with your organization, and then we'll contact you and then we'll move together. Thank you so much for being here with us. Thank you so much. We are so grateful.
Perfect. There is a hand from Wem. You can go ahead and ask your question. Welcome.
Thank you very much. Can the panelists hear me?
Yes, we
We
can.
can hear you, Prof.
Okay, thank you very much, Dr. Rabio and other members of the panelists. My name is Professor Uwemiku. I'm based in Uyo, Akwa Ibom State currently. I want to thank the panelists and the organizer for this wonderful webinar. And I quite really appreciate that FGS is becoming a more topical issue in the context of female reproduction and reproductive health issue. I think just advocacy at our level might not yield substantial fruit. Fortunately, the country have a ministry for women affairs. And I believe that if we up our game in advocacy to that level, FGS will receive more attention that is receiving now. And once again, I want to thank all the presenters for their wonderful presentation. And I also want to draw the attention that WHO ESPN is calling for expert for the technical advisory group on FGS and MGS. And I'll be happy to see some of the panelists applying to become expert of that group. Thank you very much.
Thank you so much, Prof. I don't want to mention, because yesterday I'm right now in Abuja. There's this meeting that called for the commissioners of health in Nigeria. I was there, and the secretary of commissioner forum, Dr. Amina El Imam from Kwara State was also there. We talked extensively. Yes, as if Prof, you are there. One of the two we mentioned is that we have to go to Women Affairs Ministry, and it's one of the things we are going to do. Thank you so much, Prof. Yes, we are aware of the call, and some of my members have put application to that. We are so grateful. They work, and then one of the study I cited was actually the Prof was the PI, the one in Ogun State, the pilot study. We are so grateful. Thank you for your effort.
Thank you so Thank you, panelists. What practical steps can be taken to integrate MGS into ongoing FGS-focused programs to promote gender equity in schistosomiasis control? How do gender norms and community perceptions influence access to diagnosis and treatment for both FGS and MGS? Yeah, I think there's the two questions.
I think I'm
Panelists,
gonna take, yes, I think I'm gonna take
yeah.
it on the gender issues, but I want to clarify what MGS is. I'm not sure what that acronym stands for.
Yeah, same.
Male
It's
genital
male genital
schistosomiasis.
Oh,
the male aspect.
okay, I see. I see.
Apology, yes.
All right, thank you. Okay, so I will start from the second question about gender norms and community perceptions and how it influences access. Like I shared during my presentation, we generally have seen that when illnesses or diseases or conditions affect the genital reproductive systems, they are always accompanied by stigma, discrimination because of how we perceive issues of, anything around sexual and reproductive health in that sense. So when it also affects women in particular, there's also an added layer of, the stigma of how did she come about it? How did she get it? And women already have a different level per se in the society and in the community when it comes to these issues and the dynamics between men and women. So the norms in the community definitely have a great influence on access to diagnosis, because people don't want to present at a facility for something they cannot explain how it came about, and for something that both the health worker might not even be aware and can have assumptions on what exactly is wrong with you. And even you, because of the place, the area in which it is situated, is already dealing with a lot of mental stress of what is going on with you. So that is definitely something that would prevent diagnosis from happening. So these norms, the idea is that we need to work, in the awareness and sensitization campaigns to shift these perceptions, to address, these norms, because then both the person who has had FGS and the health worker who should be able to take care of this have the awareness to be able to handle the situation in a way that doesn't leave this woman stigmatized. Now, I'm more of the gender and SRHR and HIV discussant here, and not a clinician. I want to put that disclaimer. When it comes to male genital schistosomiasis, my understanding of it is that it doesn't present in exactly the same way. Like, it doesn't have the same physical presentation like it would for a woman because of the difference in the genitals. And they would experience maybe urinary tract infections, painful urination, and all of that, which are also some symptoms of STIs, right? They also sound like symptoms of STIs. But the thing is that because of the gendered dimension and the dynamics of our society, if a man presents in a facility and complains of painful urination, there's a different way that he will be treated from when a woman presents with an ulcer or something, that she doesn't understand in her own genital tract. And so even without, and remember, the people who are mostly affected are uneducated, like they don't have access to a lot of economic, they're of low income and so on and so forth. So that intersection also plays in terms of how they can present themselves in a facility. If somebody that is a bit more educated and aware is able to come and communicate assertively that this is what I'm observing. I don't know how this has come about. It's even different. So we must also take into consideration the intersection of issues of those social determinants that makes it more difficult for a woman to access services because of preconceived their own individual norms that they've held and what the community holds collectively as norms when it comes to issues of sexual and reproductive health in particular. I don't know if I have answered that. And in terms of being practical, it really is about awareness and campaigns in which we engage with one another in communities to shift perception, to educate the communities about what FGS is about, and educate them about how it can be handled. This is exactly where I see the collaboration between the FGS, the society, advocacy organizations like ours, Medical Women's Association of Nigeria. This is exactly the Ministry of Women Affairs, the Ministry of Health. This is exactly where this multi-stakeholder collaboration can play a key role in advancing, awareness programs that help shift that negative perception that's usually comes from the kind of norms that we hold in our society. Thank you.
Great. Thank you so much, Joyen, for your response. Anyone else want to chime in?
Oh, okay. From the panelist. Hello.
Yes, we can hear you.
Oh, thank you so much, Tony. Yes, the issue of MGS, male genital stimulation, I think we are shifting attention to it because it's one of the things we discussed in Geneva that, okay, if you look at MGS2, it's complicated by infertility, you know, um, so many things. And only that there's no more study concerning MGS compared to FGS. So there's a call to that let's look at the two together and move the two together. Thank you so much.
Thank you. We have only 2 minutes on the clock. I see two questions. Let's take them on and wrap up the discussion. So there is Ibrahim Yahaya. You go ahead and pose your question. Please make it brief, and then Akinola, you'll follow.
Okay, good afternoon, everyone. I will start by thanking all the presenters and panelists for this wonderful presentation. I am Ibrahim Yahya Ibrahim, a 200 level public health student from Gombe State University. So my question here to the panelists is, how can public health students like us contribute to community health awareness or community health contribution on female genital schistosomiasis in Nigeria? Because we too as students, I think we have a role to play, which is taking awareness to our schools like health talks and campaigns and joining outreach with the organization who are responding to this great neglected tropical disease. Thank you very much. This is my question.
Yeah, thank you so much, Ibrahim. I think maybe you are not aware. I've created a platform for your class. I'm going to add you, and then our field world is coming up in the next 2 weeks. One of the things we are going to do is creating awareness about FGS. So I will handle that. I'll tell you what to be your part. As public, you have a lot of part to play. Thank you so much.
Okay, thank you.
Thank you. Akinola, you can go ahead. I think we lost her or him. Anyways, thank you everyone so much for who were able to join and participate. A special thank you to the panelists. Special thank you to FIG for making this possible.
Linda, I see Dr. Akinola is just unmuted. Sorry.
Oh, okay. Welcome, doctor.
Maybe probably it's network.
Probably. Apologies, Linda. We'll hopefully Dr. Akinola can just write in the chat.
Yes, and the discussion doesn't have to end here. I think most of our panelists shared their contacts, but also you can reach us. You can reach us out to Yenaso at Yenaso .rg on our emails, but also on all our social media platforms, X, Instagram. We can keep the discussion going. And yes, panelists, again, you can leave your emails in the chat box so that people can keep on the discussion going. And yes, and the neglect. Thank you everyone for coming and joining and staying up till now. And we're 2 minutes past the clock. Thank you everyone. Panelists, thank you so much. And participants, and for the vibrant discussion. Good evening, everyone.
Good evening and thank you.
Good evening.
Bye.
Thank you so much. Yeah.
Bye-bye.